Here we go with the fluids, electrolytes, and shock lecture. Really important lecture for the advanced EMT and at least the beginning of the paramedic student. So, the big skill that we bring to the patients as advanced EMTs is starting an IV. So we'll be doing that a lot. We practice it a lot in training and then clinical. And then when we actually are working as EMT specialists, it's one of the big things that you do, start IVs. Whether you're working with an EMT or working with a paramedic, that's going to be one of the main things that you do. And so we have to have a really good understanding of the fluids and electrolytes. So we're going to do some AMP here, follow that up with shock, and that is a super important aspect of advanced EMT training too. So between these two things and acid base, that captures a huge part of what we need to know as far as anatomy, physiology, and pathophysiology. I would say if we only could add a couple more things, the only things that we would add is the airway and respiratory component, and then maybe the neuro. That's all the essential elements for the foundational information that you need to know as advanced EMTs. And so as we start here, we see 60% of our total body weight is water. To me, I'm somewhat amazed by that. It's 60% of who you are. That's over half, and the 60% is actually a low estimation. A lot of times when you read about this, you'll see the 70% mark, and when we're doing neonatal, we'll talk about it being upwards above that. So a big part of who you are is water, and that water is dynamic. It is always moving around in your body. So it isn't like we just have water in our cells and that's where it stays, or water outside of the cell and that's where it stays. That water is, we should think of it as in constant motion. We need to know the different compartments where we would find that water, and intracellular is where most of that water is. It's 75% of it. So most of the water is there in like the cytoplasm of the cells, inside the tissue, inside the cells. The next biggest compartment is interstitial. All right, interstitial is part of the extracellular area. So inside the cell is intracellular, extracell is everything outside of the cell. First place is interstitial and then intravascular. So when I was starting out in all of this, I used to think, our fluids are in our blood. That was it. That's where most of our water is in our blood. And that's actually where the least amount of your water is settled in as plasma. So, and again, just to re-emphasize this, because it is important, this water isn't just in one place. It is always moving around. To get this water in, we drink about 1,600 milliliters a day. We also take water in through food, and then we create our own water. We'll talk about that more in acid base, but there we create about 200 milliliters a day just doing regular old metabolic processes. And for our output, we pee out about 1,500 milliliters a day. We also are going to sweat out about 550 milliliters. Just respirations or ventilations, we're going to lose 300 milliliters. And then we're also going to poop out some water with about 150 milliliters going out that way. So that's about 2,500 milliliters in and 2,500 milliliters out. After water comes electrolytes. So we need to know the anions and cations. And so let's take a moment. Can you name all the cations? There's 4 of them. They're the ones that have the little plus signs. And then after that, what are the anions? And there's only really 3 of them that we talk much about in advanced EMT and paramedic class. So they're not completely brand new words that we've never heard before. One of them is big when we start talking about acid base. So the cations are sodium, potassium, calcium, and magnesium. and the anions are chloride, bicarbonate, and phosphate. And so we need to know kind of what those electrolytes do for us. And for right now, I would like you to think of sodium and potassium. We're going to think of those in terms of how important they are for our heart and our nervous system. We're also going to talk a lot about the sodium-potassium pump in just a little bit. Calcium is really important. We should know things like it's stored in our bones, that it's really important for muscles, and since our heart is a muscle, calcium goes along with our heart too. And then magnesium is almost all the time when you read about magnesium, it'll say something like, it's the least understood cation in the body. And what I need you to know about magnesium is it helps the others get along. So I usually think of magnesium as that facilitator or human resources personnel who helps the other ones get along. And when we have too little magnesium, it seems like the others are irritated more often. Have too much magnesium, it can kind of make the other ones a little bland. So anions, the ones with the negative sign, are chloride, bicarbonate, and phosphate. And we'll see these in conjunction with those, like sodium chloride, we've already know. Sodium bicarbonate is one of the drugs that we'll give. Phosphate, we won't talk about that much at all, and that's going to be used for like intracellular acid-base balance, but again, we're not going to talk about that too much at all. What we are going to talk about is that sodium is the most prevalent extracellular cation. You'll see that in quizzes, and we'll talk about it a bunch. Sodium is the most prevalent outside of the cell cation, and then potassium is going to be the opposite of that. Potassium is the most prevalent intracellular cation. We find all of those molecules inside the cell. And so the way to remember that is the idea of salt on potato, because most people know that sodium chloride is salt, and we said sodium there. So sodium on potato, potato, potassium. So just remember that, and you'll get that answer right all of the time too. And then that's just the foundation of understanding when we start talking about that sodium-potassium pump. And so we're going to talk about diffusion, osmosis, facilitated diffusion, and active transport next. The first thing is diffusion here. And so for diffusion, what you need to know is it is the movement of solutes from an area of higher concentration to lower concentration. All right, a movement of solutes from higher concentration to lower concentration. So in nature, when we have this semi-permeable membrane, and we have two different substances on both sides of it, we will have a movement of those solutes. The solutes will, without the use of energy, and without, like, we don't have to talk about it, we don't have nervous command over it, as long as those solutes are separated by a semi-permeable membrane. Semi-permeable membrane means it'll allow for the movement of these solutes. So when we think about that, a semi-permeable membrane anyways, think about a screen, like a screen door or a screen window. We'll see that as water can pass through that screen pretty easily. And sand can also pass through that fairly easily. Sand actually takes a little bit. If you put a big clump of sand on the screen, we'll have to shake the screen a little bit to get that sand to fall through. But then if we put marbles on that screen, the marbles aren't going to move at all. So when you're thinking of the sand, think of electrolytes. All right, it takes a little bit, but it'll get through the screen fairly easy. And when you think about marbles, think about albumin and protein, maybe big sugar molecules, and they're not going to get through there very easy at all. So when we're talking about diffusion, it's going to be the movement of solutes, and the solutes are going to move from a high concentration to low concentration. And then when we deal with osmosis, osmosis is going to be movement of water, and that's going to go from a low concentration to a high concentration. So it's a little bit of an opposites day from diffusion. So Here we have a picture of two different concentrations of albumin. 5% albumin. Albumin is a protein, so those little dots in there are protein. The protein is not going to move through the screen very easily. It's not going to be permeable to those molecules. So you have 5% on one side and 10% on the other, and osmosis will cause water to move from the area of low concentration, where there's 5%, to an area of higher concentration, 10%. So water will move from the left to the right, and we will see that albumin will end up being 7.5% on both sides, because in nature they will want those things to be equal. We talk about this in reference a lot of times to what happens to a red blood cell. We'll also talk about it in reference to what happens to the water in tissue when we're giving IV solutions. So here they would like you to know, you'll see this in like every paramedic textbook will have a picture similar to this. And you'll see this on quiz questions. If you drop a red blood cell into a hypertonic or hypotonic solution, what would you expect to happen? And so when we're talking about these hypotonic and hypertonic solutions, this is like a pathological hypertonic or hypotonic solution. If we're giving the regular IV fluids that we would be given, and then we come to understand that D5W is hypotonic, when we give it, we're not going to ruin red blood cells. So this is like a pathologically hypotonic or hypertonic solution. And when we put the red blood cell into solution, if it's hypotonic, water will move from an area of low concentration. Hypotonic would be a low concentration as compared to the red blood cell. And the water would move from that solution into the red blood cell. That red blood cell would swell and then possibly burst and then be ruined. Hypertonic would do the opposite. Water would leave the cell. The cell would then shrink and die. And so that's enough about just diffusion. Next is facilitated diffusion, and with this one you have it going with the gradient again, all right? Before I didn't use the word gradient, but gradient is that idea of from high concentration to low concentration. That's the gradient. It's going down grade, like if you think about a truck going down grade on a highway. It's going from high concentration to a low concentration. With facilitated diffusion, we don't have any energy used in this either. What we have is like a helper protein, all right? That helper protein helps the solute get from outside of the cell to inside of the cell. And can you think of a time where we talked about facilitated diffusion in EMT class? Some solutes, some material needs help getting through the cell wall to get into the cell. And that would be the idea of we need insulin to help sugar get through the cell wall. And so the last thing we have is active transport. And so active transport is going to be against the gradient. So that would mean that the particles are going to go from a low concentration to a high concentration, and this is going to require energy. The only real good example that I have of this, and the one that we'll talk about over and over again, is the sodium-potassium pump. The sodium-potassium pump, it's what gives us that sodium is the most prevalent extracellular cation and potassium is the most prevalent intracellular cation. For that to happen, for that to exist in nature, we need to have a sodium-potassium pump. Remember early on I said water is always on a constant move through our body. It's at a dynamic environment where it's going from the vessel into the interstitial tissue, into the tissue, into the cell, back to being interstitial, back into the vessel. It's always moving. And the same goes for these electrolytes. So electrolytes are always moving into the cell. And with that, we have a sodium-potassium pump that's pumping the sodium back out of the cell. The sodium really wants to go into the cell. The sodium will flow from an area of high concentration to low concentration, and we have an abundance on the outside of the cell. So sodium's always trying to go into the cell. And so we have a sodium-potassium pump that's always pumping it out of the cell. At the same time, potassium is always trying to get out of the cell, and that same pump is always pulling in some potassium. That's what gives us our most prevalent intracellular cation is potassium. For us to have that electrolyte balance that we need, that's where the electrolytes have to be. For us to do this, we need ATP. ATP is the energy, all right? It's the unit of energy that we're burning. We've said this earlier, I believe, and that is water follows sodium. The way our body manipulates water is it manipulates sodium. So when we talk about diuretics, the diuretic manipulates sodium and water follows sodium. Here, if we allow water to stay inside the cell, we should also say water follows sodium. So if sodium is staying in the cell, water is going to flow in the cell. And that will allow the water to stay in the cell, and that cell will swell up and possibly cause damage to the cell or death to the cell. So that's the sodium-potassium pump. Here's a lineup of those different diffusions then. Remember, osmosis was the movement of water. And then when we're talking about the movements of solutes, we have simple diffusion, movement of from an area of high concentration to low concentration. And then that active, or I should say facilitated diffusion. And the facilitated diffusion is a great example of insulin helping sugar get through. So sugar can get through without insulin, but not near fast enough. So we have insulin there to facilitate the movement across the cell membrane. And the last one is active transport. Active transport, we're going to go against the gradient now, and we're going to use energy. That's going to move potassium into the cell where there's an abundance of potassium, and it'll move sodium out of the cell where there's an abundance of sodium. So you might be asking yourself already, why do we have to know this? There's a lot more to know about all of these fluids and electrolytes, but what we've talked about so far is important to the advanced EMT because we're going to talk about this a lot. All right. First of all, hydration and overhydration is a big part of what we need to know as EMTs and as advanced EMTs. We need to be able to understand electrolyte imbalances and what that might look like. This is the beginning of our talk on perfusion and shock, and it's the basis of some of the things that we'll talk about with the acid-base talk. So let's get into a little bit more of where all of this fluid and electrolyte stuff actually is moving around, and that's in the capillary network. And so when we're talking about a capillary network, we have an anatomy and physiology of that. And so anatomy is structure. And think for a second, what do you know about the structure of a capillary? You can write down a few factoids maybe. What do we know about capillaries? A lot of times people start with, well, they are small. Some people will say they vasodilate and vasoconstrict. They're where you might have oozing blood. And then when we talk about the physiology, we think of it as that's where a lot of the stuff happens, where, you know, the reason that we have blood and blood vessels is what actually happens at the capillary network. So here's some of the stuff that you need to know about the anatomy. First, it's a very thin-walled endothelial lining. So as blood is going into the capillary, we can't have a bunch of smooth muscle. We can't have a bunch of structure to our capillaries. If there was a bunch of structure there, we wouldn't be able to move a bunch of gases and nutrients and waste. It wouldn't move through a thick through thick tissue that we might think of when we see veins and arteries. This is down to like a thin-walled endothelial lining. We don't have smooth muscle, so we can't vasodilate and vasoconstrict at the capillary. All right, inside the capillary network, there's none of that going on. Instead, we have a precapillary sphincter and a postcapillary sphincter. Those are basically doors. We just shut the doors. When our arteries vasoconstrict down, we also are going to close precapillary sphincters. And then the physiology of it, we know, right? Oxygen and CO2 are exchanged here. Nutrients go into the tissue. Waste comes out. This is where we talked about that internal respiration. All right. So here we have that capillary network. And when we're talking about this, this is where we talk about filtration and perfusion. All right. Where this is happening, we don't want just blood to go through. We want blood to go through, oxygen to hopefully perfuse out of the vessel and go into tissue. We want CO2 to come out and go into the vessel. We want nutrients to leave and get into the vessel and out of the vessel and into the tissue. Water has to sweeping through, have it like a sweeping method, or think of it as moving out of the vessel. And then if it's water is moving out of the vessel, we need water to move back into the vessel. All right, and here's the diagram or picture that I have for that. There's our capillary bed, and in our capillary bed we're going to see red blood cells lining up and going through the capillary network one at a time. We're also going to see protein. Proteins are not going to leave. It's going to stay inside our vessel. All right. And so on the left side here, where we have the arterial side, which is under pressure, we're going to have water leave the vessel, go into tissue, and then we have to suck that water back on the venule side, or it has to be displaced somewhere else. All right. So what we have is hydrostatic pressure. Hydrostatic pressure is pretty easy to understand. It's simply our blood pressure. If we increase our blood pressure, we're going to increase the hydrostatic pressure. Decrease, we're going to decrease. This is basically just that simple understanding of its pressure, water going through pressure. If you can picture this, it's your hose at home, or your hose on a garden hose, or a fire department hose. But you have to put some holes in it. All right, put some pinprick holes into that garden hose and you'll see water leaving. Increase the pressure and you'll see more water leaving. If you decrease the pressure, less water will leave. On the opposite side of here, this one's a little less easy to understand. But we know about osmosis, right? Osmosis is the movement of water from an area of low concentration to high concentration. We don't have a bunch of these proteins inside the tissue. We have proteins outside of the tissue in the vessel. So we have an oncotic force that pulls water back into the vessel. As we lose water out of that hydrostatic pressure, we'll also gain it back from that oncotic force. So that oncotic, I would like oncotic pull there. That would look cool there too. It's an oncotic pull. We will lose maybe 10 cc's, let's say. This is just a made up word, all right? So instead of cc, let's get rid of that and let's make it a unit, all right? So we're going to get rid of 10 units of water every 10 seconds, all right? So we're going to lose water coming out, going into the tissue. We want that to happen. Water is going to flow out. It's going to carry the oxygen and the nutrients out with it, all right? It'll allow for that to happen. So if it's 10 units leaving, this getting pulled back into the vessel, let's give that only about 7 units, all right? The pressure to push the water out is going to be greater than the amount of pressure to suck the water back in. So we're going to have 10 units out and 3 units here. That's going to leave us 3 units if you're doing your math. And those 3 units are going to use the lymph channels. All right, the lymph channels will carry the rest of the fluid back to the central core of our body. We need for all of this to occur. all right? We need for water, we need to not be too dehydrated, we need for this to occur to have really good filtration and perfusion. When it doesn't occur, we start to, see the effects of it. And one of those would be dehydration if we haven't had enough water. So just to minimally talk about dehydration, we know these pretty well. It's a big part of EMT class. You need to know all the signs of dehydration. It's going to be what we usually associate with shock, like low blood pressure and high pulse, respiratory rate might be going up, a little bit of anxiety, and then that pale and cool skin. Might be diaphoretic, or they could be a little dry. If they're so dehydrated, they might be dry. Also, we would think of things like sunken eyes, poor skin turgor, tenting of the skin. Those kind of things are all associated with dehydration. With babies, we might see that sunken fontanelle. Patients might talk about not being able to pee lately. If we're taking care of somebody with diapers, we might notice that they have dark urine. Or if we're taking care of somebody in, I usually associate it with wilderness, but who may have noticed what their pee looks like. They'll say that their urine is a little darker than normal and they've been peeing less often. And so what can go wrong with this little equation here when we're talking about water leaving and water getting back out? We would also have to surmise that some things can go wrong, right? So what could cause edema here? Let's just talk about this briefly then. What could happen is we'd have an increase in blood pressure. Well, you know what? Let's talk about increase in permeability. What would happen if we simply allowed a bunch of extra water to leave? All right. We increase the capillary permeability. So now we notice here we have a bigger arrow. More water will leave. Increased permeability will allow, remember before we had 10? Well, instead of having that, we get rid of this and we make it 20, all right? So now we have 20 units of water leaving, all right? Well, on this side, we're still only going to have 7 units coming back, going into the venule side. So if that's true, and only 3 are easily going to go this way, well, we're going to have extra blood staying, or extra water. We're not talking about blood. We're going to have extra blood left in the tissue. So increased capillary permeability will cause edema. Can you think of any times where we talked about increased permeability causing that? One of the big times is anaphylaxis, all right? Another one is sepsia, all right? Both of those are good reasons to have edema caused by increased capillary permeability. The next one would be an increased blood pressure, the one that I started to mention before. Again, when we're talking about that, this arrow got bigger than this one here. So again, let's say we're losing 15 units on this side because our blood pressure is simply up. Our blood pressure went up and now we're losing more water than we used to. Again, what did we pull in? We're going to pull in 7 this way and 3 this way. We're going to end up with more water in our tissue than what we want. So can you think of any time where we talked about an increased blood pressure? How about a patient who has an increased blood pressure and puffiness or systemic edema, and then another part of that patient's problem was they pee out protein. What patient had that? That was the preeclamptic patient, all right, preeclampsia. The next problem that could give us edema is a decreased oncotic force. Where did our oncotic force come from? It was this albumin. So if we have a decreased amount of protein in our system, we will still get, you know, and our blood pressure remains the same, we'll have a problem here, all right? We'll still be losing 10 here. Remember that? We had 10 units leaving. So we would still have 10 units leaving here, but on this side over here, we would, instead of having 7, maybe only have 5. 3 would go this way. We're slowly but surely going to have 2 units in surplus, giving us some edema in the tissue, all right? So what would cause us to have decreased amount of protein? 2 things that I can think of right away is a burn patient very often denatures their protein, and the second one would be that, you know, malnourished people can have decreased protein. And then the last thing that can cause edema is this lymph system blockage. Again, you have fluids going in this way, fluids going in this way, but all of a sudden we have this big old blockage right here. Oops, we should probably get rid of that. So we have that big blockage. That's going to give us a bunch of water here. We're not doing any fluid going through the lymph system, so in that area we're going to have edema. All right. The difference between this lymph problem and the first 3 things that I talked about was with the lymph system thing, it's probably only one appendage where you're having problem. And so here's our overhydration slide. Some people will have overhydration, and that basically, in a very simple terms, is they overhydrated. They drank too much water. There are some other causes. I like to think of this in ways of basically our body isn't distributing water properly, and that will give us the look of overhydration. So when we are overhydrated, our body fluids become hypotonic. Right here is the new piece of information, the one that you might not have known. We would recognize our body fluids as hypotonic here. The patient will pee more often. That pee is usually going to be clear. They could have some edema and weakness. Pulmonary edema is all a part of overhydration. And this person can end up having altered mental status, seizures, and even death from this. On the opposite side is dehydration. We're fairly familiar with this, and the opposite is going to be true. Something new that we might not have known is our body fluids are hypertonic now. Here we have the thirst, the darker urine, the decreased output, all of those signs of shock that we talked about earlier. And again, people can die of dehydration. So we can have this all the way to where we have an altered mental status and shock and death. And so when we talk about shock, the big thing here is we have blood that's going to go round and round. We have air that's going to go in and out. We don't want to change those things. Air shouldn't be going round and round and blood going in and out. So we need for this to be intact. Our heart, our vessels, and then what's inside the vessels, which is our blood. When we're talking about shock, we're really going to emphasize this area right here. All right. Now, as a EMT, you kind of thought of it as a whole body type of thing, but now we're going to drill it down to what's happening in the tissue and at the capillary level. And so the first thing is, let's talk about that, what happens at the capillary level just a little bit more. We already talked about the idea that we have a sodium-potassium pump, and that sodium-potassium pump runs on ATP. And so we need ATP at the cellular level, at the tissue level. And so how does that happen? Well, we build ATP out of glucose and oxygen. And we do that in basically a 2-step method. We also have this electron transport cycle, and we're not going to talk about that very much. We're going to talk about these first 2, and we're going to use the term Krebs cycle very often. All right? So this is the way we create ATP. And the first one is glycolysis. And you may have learned all of this kind of hoo-yah in high school. We don't have to know all of this. We need to know the term glycolysis, all right? With the term glycolysis, it's the first way that we break down sugar and we get a little bit of ATP from it, all right? So we break down sugar and we get a little bit of ATP. We do not need to use oxygen, so it's an anaerobic process, all right? When we do this, we take those glucose molecules, we get a couple, 4 maybe ATP, and we're also going to have some byproduct, and that's going to be pyruvic acid. If you like, a little advanced knowledge is this all is happening in the cytoplasm on the way to the mitochondria, and at the mitochondria, that's where we're going to have this citric acid cycle, and that's going to be aerobic. So before we just needed to have glucose, now we need to have oxygen, all right? We're going to take that pyruvic acid that we made in glycolysis, we're going to put that into the old, I like to just call it the old Krebs cycle machine or the citric acid cycle, whatever you'd like to call it, and we're going to get a lot more ATP, all right? So here we're going to get some CO2, some water, and some ATP. And this is enough ATP to sustain life. If we're just using glucose, it's not going to sustain life for long. We need to have oxygen in order to supply our body with the ATP that it needs. And so when we talked about shock and EMT, we called, the definition of shock was inadequate tissue perfusion. For some reason, a pump failure, a pipe failure, or fluid loss, we were no longer perfusing the tissue. And so let's just talk about those things for a little bit. At first, there's pump failure. Something went wrong with the pump. And so usually this is a heart attack or several heart attacks has caused there to be death of muscle, and now the muscle simply does not have enough strength to give you the blood pressure that you want. It could also be, I'd like to talk about this in reference to maybe it's too slow of a heart or too fast of a heart. We'll talk more about that as we get to paramedic school. Obstructive shock, I usually bump right over to trauma when I think of obstructive shock because tension pneumo and cardiac tamponade are both a big part of this. But it's a blocked vessel, so pulmonary embolism is a big part of obstructive shock also. We'll talk about each of these when we get to PE in the respiratory chapter and tamponade and tension pneumo when we get to trauma. Right now you should realize there's a type of shock called obstructive shock, and it's basically something is obstructing circulation, all right? So the next one is pipe failure, and that's a big one. We'll just talk about these in basically a superficial way right now. And here, when we're talking about pipe failure, another way I refer to this as container failure is your container just got big. All right, so you have a certain size container that has to have so much pressure. When the container gets bigger, it's hard for your heart to keep up with that, and you will lose pressure in that container. For a firefighter, you might think of that as you have the same pump, the same pump strength, the same waters per gallon leaving the pump. Your hose size just goes from 2-inch to 5-inch. You will lose pressure when you get to the 5-inch hose. When you're pushing that same amount of water through there, you'll have lower pressure. So your pipe failure. There's a few different kinds of pipe failure that we'll talk about. Can you think of the three different things we'll address here just shortly? The first one is anaphylactic shock. Anaphylactic shock is a histamine release. We'll talk about it more in immunology. So for some reason, you know the basics of this from EMT. You have that big old histamine release, and that's going to give you your signs of anaphylaxis, which the big ones we talk about are the airway problems, a little bit of lung problems, and then you have shock. low blood pressure. You may have a short compensatory phase, and then you're going to have the true shock where you have the low blood pressure. And we know this is, bee stings are a big part of this, and then EpiPens are the way we fix it. The next one is neurogenic shock, and we learned about this as EMTs too. And this is a spinal cord damage, which isn't allowing for your brain to communicate with your body as well as it has before. A big part of this is the loss of your sympathetic nervous system. So you're not going to have an ability to have a compensatory phase. You lose your compensation. So in neurogenic shock, you go right to the decompensation side. All right, a low blood pressure. You don't get a fast pulse because you don't have sympathetic nervous system. You don't get pale, cool, and clammy because you don't have adrenaline. All right, for you to have neurogenic shock, you have an inability to talk to your adrenal glands, which sit on top of your kidney. So you need your spinal cord to be intact down to your thoracic area. A lumbar fracture does not cause neurogenic shock, because if you have a lumbar fracture or a low thoracic spine fracture, you'll still be able to talk to your adrenal glands. If you can talk to your adrenal glands, you can release adrenaline. Your nervous system will be intact enough to be able to give you the vasoconstriction that you need. So you will be able to figure things out easily when you have a low spinal fracture. Where it becomes a problem is the cervical spine fracture and the high thoracic spinal fracture. Again, loss of sympathetic nervous system. And the last one that we'll talk about here is the septic shock, and that's a big one nowadays. We'll talk about this a lot in Medical Emergencies 1 and Medical Emergencies 2. Here, because of the toxins that are released from dying or really surviving bacteria, you'll have increased permeability, you'll have vasodilation, some toxins affect your heart, so you'll have decreased output from the heart, you have decreased strength. So that's a three-pronged assault. You're going to be having a problem with all three things with your cardiovascular system. Pipes, pump, and product are all going to be harmed. And so the last one, and the one that we'll talk most about, is the fluid loss. When you're bleeding to death, or when you've lost your plasma, like dehydration or whatever it would be. So here, the first thing that we'll talk about just minimally is the average person has about 5 liters of blood. That person would be defined as a 175-pound college-age male. They have about 5 liters, and goes up from there, of course. So I would say I have about 6 liters because I'm a bit bigger than that. Generally, a loss of blood at around 15% isn't a big deal. But once you start going over 15%, now you'd be in stage 2 blood loss. Depending on the nature of that blood loss and the comorbidity of the patient, that can be dangerous then, all right? It could end up being deadly for some. So let's talk about what happens in the body during shock. So we can start this off with a bit of a case review. So let's talk about a fallen hiker. Someone's out in the wilderness and fell off a steep rock, fractured a hip, and she has lost about 1 liter of blood. So a wilderness rescue team is bringing her back to the trailhead, and you're waiting there. So the first part, while we're just contemplating what's going on with our patient, as we sip coffee waiting for our wilderness team, what in the body will recognize that there's a low pressure? And where is that thing? So what is that called? Earlier, when we talked about respiratory rate, we talked about a chemoreceptor measuring CO2 and pH, measures oxygen. What measures pressure? And that's a baroreceptor. The baroreceptor is in the same areas: carotid bodies, aortic arch. A barometer measures pressure in the atmosphere. So a baroreceptor measures pressure in your body, let's say, like in your arteries more specifically. And those baroreceptors are hooked up to nerve fibers, all right? So we have nerve fibers here. This baroreceptor here, aortic arch, I think these are all going like that. So these use the glossopharyngeal nerve, all right? So the glossopharyngeal nerve sends a message, boop, you see those arrows right here, to your medulla saying, hey, low pressure. So these are actually something that are always being used, and these receptors could say something like, hey, brain, by the way, our pressure is going down a little bit. You might want to do something about that. The hypothalamus would probably pick up the ball there and say, hey, well, I'll just tweak the antidiuretic hormone. It's called the antidiuretic hormone. So if we release antidiuretic, that means we're not going to diurese. We're not going to pee. So if I release ADH, I keep my water. So if we're having a slight problem with a low blood pressure, our hypothalamus will say, hey, let's release some antidiuretic hormone and we won't pee. And then your pee is going to, you're going to, in your kidneys, keep your water, all right? You'll still get rid of some of the bad things like urea and such, and that helps you have a more concentrated urine. You'll keep your water though. Hence, when you pee later, you have a darker, some people say smellier urine. And so for some people, you won't pee for a while, all right? When we take care of, let's say when we're taking care of a Marine who's dehydrated at a battalion aid station, what we do is we start an IV and we give them fluids. We don't have to watch fluids so carefully in healthy Marines, so we're a little, I guess you'd say, aggressive with IV fluids. We don't care how much we give them, to tell you the truth. We can go through a bunch. We track it and everything, but we give them enough until they want to pee. Once they want to pee, that their body is saying, hey, it's time to pee. We have enough fluid, so we're good to go. So it's not really based on anything except the Marines' willingness or want to go to the bathroom. And then that first urine, if it's dark, we'll keep them until they're peeing clear, and we'll keep that IV fluid going. So here, those baroreceptors are going to measure, send it through that sensory nerve, and then again, these carotid bodies, there's baroreceptors and chemoreceptors there. Here, when we have a message from that baroreceptor that says, holy cow, our pressure just went down in a fairly significant way, that message is going to go through the hypothalamus. Remember, one of the things for the hypothalamus is it's a switchboard for the brain. And it's going to go right to the medulla, and the medulla and the brain are going to basically say, what the heck? We need blood, all right? We need to have pressure. We need to constantly perfuse the brain. If the pressure is down, that's kind of a serious problem. It has implications to our ability to survive. So it will push that easy button, all right? That easy button is the sympathetic nervous system. And we'll get all of the things that we know are associated with the sympathetic nervous system. Increased heart rate, increased respiratory rate, increased respiratory volume with that, increased blood pressure, and you'll get vasoconstriction where we want it and vasodilation in other places. Some other things is your pupils will dilate, your blood sugar is going to go up, your higher brain functions decrease. That's right, epi makes you stupid. So your primal brain will take over in this process, all right? So all of these, sympathetic nervous system, same nervous system that we use when we're scared, is going to be the one we use when we need to stay alive for shock. Some other things that are going to happen momentarily, let's say. So the sympathetic nervous system is going to kick in right away. Our nerves are going to go in and immediately cause us to have those things that we just mentioned, like vasoconstriction and increased heart rate. It's also going to go talk to the adrenal medulla, which are on top of your kidneys, and get you to release epinephrine. And that's going to sustain your increased heart rate, increased blood pressure, vasoconstriction where you need it. Along with that, our posterior pituitary is and that's manipulated by our hypothalamus, is going to release the antidiuretic hormone like we talked about before. Our kidneys are going to recognize this and release aldosterone. ADH and aldosterone super closely related, and they both are going to tell you to, what do you think? How are they going to tell your kidneys to hold on to water? It's going to manipulate sodium. All right. The way both of those work is it's going to say keep our sodium. If we keep our sodium, water follows sodium, so we'll keep our water. And then we'll have the renin-angiotensin system. And let's talk about that for a little bit. Here, it's our kidney will, without neuro innervation. The brain doesn't tell it to do this. The kidney recognizes low glomerular filtration, a low pressure in the glomerulus, and it will say, hey, I am going to release renin. All right, so it releases renin into the system. Renin then, as it is in the blood system, will come across something called the angiotensin converting enzyme. All right, angiotensin converting enzyme. So you're going to have to deal with me while I write this out. This is fairly important because it has pharmacology implications. So hopefully some people are catching on to what I'm talking about already. Angiotensin converting enzyme. If we were going to come up with an acronym for angiotensin converting enzyme, what would that be? What would that be? Indeed, it's an enzyme, so we will not spell that out. We'll just go with the NZY. How about? Ooh, maybe I can figure it. Ooh, look at this. I can figure it right into the side. Boom. Angiotensin converting enzyme is ACE. All right. So when we talk during pharmacology, I very often talk about the little blood pressure medication known as an ACE inhibitor. All right, so this is a very popular medication. And so here, while we're talking about the renin-angiotensin system as it relates to shock, our kidneys will release renin. Renin will come across ACE, angiotensin converting enzyme, and that will give us angiotensin 1 and then angiotensin 2. All right. When we have angiotensin 2, and we'll talk minimally, we'll talk a little bit more about how this works in the future. But when we have angiotensin 2, that is a vasoconstrictor. All right. So why would someone take an ACE inhibitor? To lower their blood pressure. How does that work? It causes our body not to be able to cause vasoconstriction. So you could call that a relative vasodilation, lower our blood pressure. So here, release renin. Renin, through a step-by-step process, becomes angiotensin 2. Angiotensin 2 causes vasoconstriction, helping out our epinephrine, which is trying to do the same thing. We're going to release glucocorticoids. We're going to release glucagon. Both of these are going to, in a very basic way, give us some sugar. And then the last thing is we're going to release some blood from our spleen. So we don't talk about the spleen very much, but one of its duties is it sequesters red blood cells that we are thinking are kind of in their twilight years. All right, their Medicare age. They're over 100 days old red blood cells that they're not at 100% anymore. So our spleen will sequester those, will set those aside and get ready to excrete them, get rid of them. Well, we have about 250 cc's there. So when we really need red blood cells, our spleen will say, well, here you go. They're not the best, but they'll help. All right. And so let's get back to our mountain hiker who fell 24 foot off from a rock face and has a liter loss of blood. If you remember, our baroreceptor recognized that we had low pressure. When our baroreceptors told our medulla that we had low pressure in kind of an emergent way, they hit the sympathetic nervous system. You hit the sympathetic nervous system by both nervous response and endocrine. Using epinephrine, we're going to cause our heart, I should say, our artery, our artery to vasoconstrict. And then remember, we have these pre-capillary sphincters. There was one right behind this Ghostbuster sign. All right, these pre-capillary sphincters are going to constrict, and blood then is going to go from here to here. All right, so we will shunt blood to the core. We've heard that as EMTs, right? But this little venule right here, this is the shunt. That's actually that's the medical term for it. All right, we're going to shunt blood, and it's going to go, our oxygenated blood is going to go from this periphery back to the core without losing the oxygen. So what's going to happen in this area here is no perfusion. All right, no perfusion. No water is going to go through there, no filtration at all. There's not going to be any oxygen going into there, and there's not going to be any nutrients. So here we're going to go back to our picture for filtration, all right? So here we have that Ghostbuster sign where we've closed down the precapillary sphincters. If blood is shunted away from this tissue, the tissue is not getting oxygen. Another way to say that is anaerobic, all right? So it's anaerobic metabolism. And when we are in an anaerobic metabolism, that is going to lead to not having enough adenosine triphosphate. All right. Remember that glycolysis will happen if there's sugar there, and there's sugar there. And remember, we have some glucagon and such, so it's not unheard of for this tissue to get some sugar, but that sugar is not going to give us enough ATP. We need to have aerobic metabolism in order to sustain the amount of ATP that our cells need. Why do our cells need ATP? Our cells need ATP for that sodium-potassium pump. So if that sodium-potassium pump's not working, there's going to be a problem. And so here, when we're talking about that tissue, no oxygen pretty much means no ATP. It's not enough ATP. The comparison is like 4 to 36, all right? Instead of 36, here you get 4, all right? No ATP, and you're not going to have a sodium-potassium pump. And remember, if we're vasoconstricting in this area and we're causing our precapillary sphincters to close, we're paying those guys ATP. They don't work for free. So when we're making those guys work to give us vasoconstriction and closed precapillary sphincters, we're burning ATP. If we don't have a sodium-potassium pump for those cells in the tissue, sodium is going to stay inside the cell. What follows sodium but water? Water will flow into the cell, and the cell is going to burst. That bursting cells means cell death. Cell death means tissue death. And so what was the most prevalent intracellular cation? Remember salt on potato? Potassium. So potassium is supposed to be intercellular. Well, if those cells are bursting, that potassium is now interstitial. Lysosomes are one of the organelles in our body. If you're bumping through your A&P course, you know that lysosomes are like the garbage truck. All right, they go around and just pick up intracellular debris. They're kind of dumb. They're not really good at recognizing self and non-self. They pick up what they recognize as garbage. And so now when these lysosomes are outside of the cell, they could be causing some damage too. And here we also have pyruvic acid. We're doing some glycolysis. We had sugar in that area. We have glycolysis. Glycolysis is going to give us pyruvic acid. That's not going to be used in the citric acid cycle because we don't have oxygen. So pyruvic acid degrades into, what does pyruvic acid degrade into? Does anybody know? Butyl? That's lactic acid. So at some point, there's not going to be enough ATP to maintain the vasoconstriction and those precapillary sphincters. Your blood is going to be hyperkalemic because those potassium molecules are going to migrate to the blood. The blood is also going to become more acidic because of lactic acidosis. And we're also going to end up with some microemboli there. That could be from those lysosomes. Remember, cell destruction. It also is true that the precapillary sphincters are going to open, and as those precapillary sphincters open and they go into the capillary bed, there's something that could happen called rouleau formation, and that's going to give you some emboli also. The blood can become stagnant in the capillary network for just a short period of time, and that could give us some clots. So when we're talking about all of this stuff, when it says there will not be enough ATP to maintain the sphincters, but let's say we're at the 1 second before they're not able to maintain. So we are still maintaining those sphincters. While we're maintaining them, all of those things are true. We're still getting hyperkalemia. We're still getting acidosis. We still could be getting some microemboli. So what do you think that the patient's blood pressure would be at this point? Well, one of the clues is they're compensating. All right. So we associate compensated shock with a normal blood pressure. The diastolic can actually be up. So at this time, they are compensating. So think about that. When you're taking care of a patient who has a normal blood pressure, they still are struggling with all of this stuff at the tissue level. They still are building their way towards hyperkalemia, lactic acidosis, and the possibilities of having microemboli. Once we lose the ATP, those things open up. That's where decompensated shock starts. And we really can't tell if we're in decompensated or irreversible. Irreversible is basically there was just too much cell death at the organ level. All right. So we'd have MODS, which is multi-organ dysfunction syndrome or death syndrome. So here, irreversible, I always think of that as something we don't really know that the person was or was not in irreversible death until, if he survives the surgery, he still may die. And he was probably in irreversible shock when we had him in the pre-hospital side. Doesn't mean you already lost your pulse. And so here's the stages of hemorrhage, and I'm only going to talk about this briefly. We'll talk about this a lot more in trauma. Stage 1 and 2 are usually associated with compensated shock. Stage 3 is decompensated shock, and stage 4 is the patient is probably in irreversible shock. And here's the thing right from your book. So I think they use let's look at this. I would say, yeah, the same. It's not quite the same, but it's almost the same as what you'd see in your EMT text. All right, this one's from the paramedic textbook. I like to make a big deal out of this a little bit, is you're probably doing fine here. All right. When you give blood, you give 500 milliliters of blood. And you shouldn't be thinking there's a lot of symptoms associated with giving blood or that there's a danger of being in a shock that we have to treat. The worst that happens is juice and cookies pretty much. In class 2 hemorrhage, we're at 15 to 30% blood loss. And again, this goes back to that 175-pound college-age male with 5 liters of blood. That makes those numbers make sense. When you've lost this much blood, we start to see things like a pulse that is above 100 here. And I'd like to note that your systolic blood pressure is normal. Pulse pressure is narrow, and that means your diastolic went up. All right, your diastolic went up. The patient might be mildly anxious, and they'll kind of look like they're in shock. All right, so the urine output is decreased if you care about that. And so here, this person really needs crystalloid fluid. All right, here we have fluid replacement. We can give them crystalloids, right? But that's a low mortality rate over here. You're probably not having any problem. You start an IV to make them feel better quicker. For this patient who's lost over 15% of their blood volume, an IV and then fluid bolus correction for their fluids is important, all right? This class 2 hemorrhage has a mortality rate, all right? So we give this person crystalloids very often in the hospital. That's all they need, all right? What they really need is fluid, all right? So when we get up to this class 3, they have substantial blood loss here, all right? 2 liters of blood loss is going to be a big blood loss. Here we have that low blood pressure, all right? This is from the previous slide. They very often are going to be in a decompensated shock when we see them. We're going to start to see things like delayed capillary refill and then a confusion. And so here, this patient, we need to give them IVs, all right? Where this one needed at least one IV and a good fluid bolus, probably a few liters of water to get back up to speed. This guy needs fluid, and to really lower mortality, he needs blood. Not wants blood, needs blood. If you really want to impact mortality on this guy, he needs blood, all right? So this guy over here in class 2, he needed fluid to lower mortality. Want to get him feeling better faster? You probably give him blood. He didn't need blood. All right, this guy doesn't need blood. He often gets blood in today's modern medicine. This one here needs blood. All right, this is a mandatory, of course, as it was here, but now that importance of blood is way up there. And then class 4, here is that previous slide put it as irreversible. That's kind of a JB learning side of it. Remember, you really don't know that you're not going to know exactly how much they lost and such pre-hospital, but we kind of should err on always thinking, well, he's probably just in decompensated shock when we're taking care of him. This patient needs a surgeon, all right? Just water and blood isn't going to do it. Not only do they need those, if this guy is going to survive this much blood loss, over 40%, that person needs to see a surgeon pronto, like yesterday. And then our treatment, only 2 slides left here. A big treatment, just to talk about treatment here, to position the patient correctly. When we have a patient who has uncontrolled blood loss, the position is probably supine. When we've controlled blood loss or we've lost plasma for some other reason besides blood loss, then we can put him in the Trendelenburg position, just lift up his legs and make him feel a little bit better. When we're talking about the overall management, we're going to do the ABCs, do what we need to, treat the cause. So when we go back to those other things like cardiogenic and septic and anaphylactic shock, we'll treat those causes. The obstructive shocks have their own treatments. Maintain body temperature. We'll talk about that way more in trauma, but we have to put the blanket on. Just knowing what we know as an EMT is good enough. Put a blanket on them. Put them on oxygen, probably early and often, and you might as well put them on a lot of oxygen. IV fluid resuscitation, and let's talk about that for a little bit. If somebody loses a liter of fluid, we need to give them 3 liters of fluid to replace a liter of fluid. The reason for that is the crystalloids that we give, 2/3 of them will leave the vessel and go into tissue. All right, that's where all the fluid is, right? In the tissue, inside the cell. So when we're just trying to do volume expansion or replace the volume in the vessel, we have to give 3 liters to replace a volume of blood out of a vessel. So that's kind of fun fact stuff though, all right? Otherwise, if somebody is, when we're talking about IV fluid resuscitation, if somebody has uncontrolled bleeding, the way we measure our fluid resuscitation is we just want them to have a peripheral pulse. Another way to say that is we want them to have a blood pressure of 90. somebody basically put a blood pressure of 90 is equal to a radial pulse, which is kind of funny. We can talk more about that as we go, but that's completely made up. No research proves that at all. But it is something that we just kind of understood as, hey, this is true. We want it to be true, so boom, it's true. So if, and in a written format anyways, we'll see that. Blood pressure 90. If someone's bleeding to death, a continual bleed, an uncontrolled bleed, that's going to be a bleed in our thorax, in our stomach, or in our chest. When they're bleeding that way, in our pelvis would be another good place to bleed like that. We don't want to give them a bunch of IV fluid, increase their blood pressure, and have them bleed more. We want to maintain a blood pressure that is only going to maintain their brain and their vital organs. So a blood pressure of 90 is all we need. All right. You see mentation with that too. In the absence of a head injury, we just want the casualty to be able to think and talk. All right. So talking to your patient is another way of keeping them, balanced as far as, should I give you more fluid or not? Probably the best way is an assessment of their radial pulse, assessment of their blood pressure. If they have a radial pulse, think about it this way, probably the best way to think about it. If they have a radial pulse, they're perfusing their kidneys. If they're perfusing their kidneys, they're perfusing their lungs, they're perfusing their lungs, they're perfusing their heart. If they're doing that, their brain is going to be okay. Those are the only things that we care about. We don't care about the rest, all right? As long as we're able to perfuse those things, they're going to be all right. So we don't care about their hand, but that's where we're going to check the pulse. We just want them to have a pulse. A carotid pulse might not be good enough. So we give enough fluid to get them a radial pulse. Doesn't have to be a great radial pulse, just has to be a radial pulse. We try to not let the person drink because they're probably open for surgery that afternoon. All right, so they're going that way. I think that's it for trauma management. Again, we're going to talk more about those fluids, but let's talk a little bit more because I forgot one more thing. Another fluid bolus that's always right is not always right. Is right when we have controlled bleeding. When we have controlled bleeding, it's 20 milliliters per kilogram. 20 milliliters per kilogram. An easy way to think about that is 10 milliliters per pound. So if I weigh 200 pounds, you just give me 2 liters. Just like that. That's that easy. You don't have to half and times by 20. You just multiply pounds by 10. Another way to say that for you math geniuses is put a zero on their, an extra zero on their pounds, and that's their fluid bolus. And that's it, all right? But we don't do that to people who have uncontrolled bleeding. Uncontrolled bleeding, we just get them up to have a good radial pulse and call it good.